Good morning and good afternoon. I'm Jackie Hauser, Senior Marketing Manager for Coagulation at Siemens Healthineers, and I would like to thank you all for joining today's webinar on the laboratory investigation of von Willebrand disease. We are very excited to host this webinar today. Von Willebrand disease is one of the most common disorders that affects both men and women equally. However, the diagnosis of von Willebrand disease has often been challenging due to broad clinical presentation and variability in testing methods, for instance, Ristocetin cofactor activity. Today, you will learn more about the laboratory investigation of von Willebrand disease, focusing on the different tests involved in the diagnosis. In his presentation, our speaker will discuss the new guidelines for diagnosis and newer assays for von Willebrand factor activity. Speaking on this topic, Dr. John Mitsios, medical sciences partner at Siemens Healthineers, will help you to describe the different stages of hemostasis, describe the first-line testing for von Willebrand disease, and describe the second-line testing for von Willebrand disease. Dr. Mitsios has his PhD in chemistry from the University of Ioannina, Greece. He completed his postdoctoral fellowship at the University of California, San Diego, and his clinical chemistry fellowship at Washington University, St. Louis, Missouri. His primary research interest throughout education and training has been coagulation, with an emphasis on platelet function and biology. Dr. Mitsios has been a member of the faculty at Weill Cornell University as an assistant professor of pathology and laboratory medicine, as well as an assistant attending clinical chemist at New York Presbyterian Hospital. Most recently, before joining Siemens, he was assistant director of the Special Coagulation Laboratory at BioReference Laboratories. Additionally, Dr. Mitsios has co-authored 21 peer-reviewed articles and 3 book chapters. And with that, I will now hand things over to you, Dr. Mitsios.
Thank you, Jackie, for that introduction. So today we're going to start off with some learning objectives for today's presentation. First, we're going to describe the different stages of hemostasis as a refresher for coagulation. Then we're going to describe the first-line testing for von Willebrand disease, and then finally round out the conversation on looking at the second line of testing for von Willebrand disease. However, before we talk about the diagnosis or the laboratory investigation of von Willebrand disease, I want to just kind of refresh everyone around coagulation. So we know that coagulation is really all about a balance. So there's a nice balance between both thrombosis and fibrinolysis. However, if the scales are tipped in favor of fibrinolysis, then therefore there's an increased risk for bleeding. On the other hand, if the scales are tipped in favor of thrombosis, there's an increased risk for thrombosis. When we talk about coagulation, we know that coagulation is really composed of 3 distinct stages. The first stage is referred to as primary hemostasis. This is where we have the initial adhesion and the subsequent aggregation of platelets. This results in any type of, let's say, injury within the vasculature results in the exposure of various bioactive compounds like collagen and von Willebrand, which is the topic for today's discussion. This results in the recruitment of platelets to the area of injury and then the subsequent activation of those platelets. This then leads to secondary hemostasis, where we have the activation of the various clotting factors and the subsequent formation of fibrin. And finally, we have tertiary hemostasis, which is really that fibrin cross-linking and the subsequent fibrinolysis. And this is where we have the formation of the platelet plug, which really results in that stopping of any type of bleeding or resulting in a subsequent repair of the damaged endothelial layer. When we talk about hemostasis, so I always like to go back to the coagulation cascade because that plays an integral role in the activation and both specifically for that of secondary hemostasis. The coagulation cascade is composed of 2 distinct pathways. The extrinsic pathway, which is really the activation via tissue factor, that results or culminates into the common pathway, which is the formation of the activation of thrombin and the subsequent formation of a clot. We also have the intrinsic pathway, which is really the surface activator, including factors 8, 9, and 11, and in addition to that, factor 12, again, culminating into the common pathway, resulting in the formation of a clot. We also have anti-fibrinolytic mechanisms, which results in the activation of plasminogen to plasmin via tissue plasminogen activator. And this results in fibrinolysis and the formation of fibrin degradation products, as well as probably the most well-known marker of coagulation in D dimer. In addition, we have antifibrinolytic mechanisms such as the activation of PI1 or plasminogen activator inhibitor, which regulates the fibrinolytic pathway, as well as having natural anticoagulants like antithrombin, as well as protein C and protein S, all of which work together to maintain that balance in coagulation. Now, let's transition now to the topic for today's discussion, which is really the diagnosis or the laboratory investigation of von Willebrand disease. Von Willebrand disease is actually considered one of the most common bleeding disorders and affects both men and women equally. However, I'm struck by this comment or the statement that's on the slide where it says, the CDC estimates it takes women an average of 16 years from the onset of symptoms to be diagnosed with von Willebrand disease. And this kind of really highlights the intricacies and the challenges associated with diagnosing von Willebrand disease. Because one, it has very common symptoms. For example, you can have heavy menstrual periods that last longer than 7 days, especially for women. You can have prolonged nosebleeds, easy bruising, as well as bleeding from the gums. So it's really important to be able to accurately diagnose patients with von Willebrand disease. Now, when we talk about von Willebrand, I mentioned in the kind of the introduction where when we have damage to the endothelial layer, we have exposure of various bioactive compounds, one of which obviously is von Willebrand factor. Now, if you can imagine that von Willebrand factor acts as kind of a sticky string, that it's exposed, it unfurls or becomes more, it is elongated, especially under very high shear stress or very high shear rates where there's a whole lot of turbulent blood flow. As it unravels, there's longer and longer the sticky string or this adhesive glycoprotein becomes, being able to recruit platelets to the area of injury. In addition, its size is regulated by a molecule called Adams TS13. And essentially, this molecule cleaves von Willebrand in specific places, regulating its size, keeping a size consistent with that of more refined or kind of controlled activation versus having larger molecules resulting in a significant thrombotic state. Now, there is a disease stage, which I'll talk about in the coming slides, which is called TTP, or thrombotic thrombocytopenic purpura, which is an Adams TS13 deficiency, which there's an unregulated size of von Willebrand resulting in enhanced thrombosis risk. But the importance here is that von Willebrand acts as that sticky string of this adhesive glycoprotein that's able to draw the platelets to the area of injury. Now, von Willebrand actually has multiple functions. One of its primary functions, it acts as a chaperone, or also referred to as like a molecular bus for factor VIII. When factor VIII is exposed in circulation, it's easily proteolized. It undergoes proteolysis. However, von Willebrand has a special spot for factor VIII to bind to, protecting it from proteolysis. In addition, von Willebrand is a positive acute phase reactant, as is factor VIII. So under inflammatory conditions, both von Willebrand and factor VIII are significantly increased, providing this thrombotic risk, especially in inflammatory conditions. And we saw this in patients which had COVID-19, where they had high von Willebrand as well as high factor VIII levels. In addition, von Willebrand plays an important role, especially in very high turbulent blood flow areas. So if you have stenotic arteries or arteries that have bifurcations or these sharp turns where there's enhanced blood flow, it could result in further activation of von Willebrand, resulting in increased thrombotic risk. Also, von Willebrand can play a role in atherothrombotic complications, but I'm not going to go through this entire slide, but knowing that von Willebrand plays an important role, especially for recruitment of air plates to the area of injury, and that it is a positive acute phase reactant and can be elevated in inflammatory conditions. So von Willebrand actually has two main functions. One, it binds to the subendothelial collagen after vessel injury. So we talked about the recruitment of plates to the area of injury. And it is multimer dependent. And I'll show some pictures in the coming slides which shows the differentiation of the multimer distribution of von Willebrand. It also is able to capture and activate platelets via glycoprotein 1b, and again, multimer dependent. And we talk about how the association of collagen, multimers, or von Willebrand, and plates play an integral role to make that platelet-rich area, especially in the initial stages of vascular repair. And it plays an important role as a chaperone for factor VIII in plasma. We talked about this before, is that how do we control or regulate the size of von Willebrand? And that's where we have this Adams TS13, which regulates the size of von Willebrand. And it is shear-induced activations. Again, when we talked about the bifurcations or turbulent blood flow, we can have the exposure of these von Willebrands. So Adams TS13 regulates the size, therefore, in an attempt to regulate the thrombus that's going to essentially be formed. So patients who have Adams TS13 deficiency have unregulated multimer size, therefore resulting in enhanced thrombotic risk. So when we talk about the challenges for diagnosing von Willebrand disease, this is where it becomes a little bit challenging because one, it presents with very common symptoms, nosebleeds, frequent menstrual, prolonged menstrual periods lasting longer than 7 days. So it's very important for the clinician as they're undergoing or looking at these patients with suspected von Willebrand disease to get an accurate personal as well as accurate family history of bleeding symptoms. And of course, as we move into that, then the next stages of diagnosis is really to look at the laboratory evaluation that confirms the von Willebrand defect. Before we talk about the laboratory investigation, I just want to classify von Willebrand disease. The inherited form of von Willebrand disease is broken up into two categories. The quantitative deficiency, which is normally referred to as a type 1 von Willebrand disease, which is a partial quantitative von Willebrand factor deficiency, and it has a prevalence of about 85%, which is referred to as more of your more common von Willebrand disease that you would see. Type 3 is a complete or virtual complete absence of von Willebrand and a decrease in factor VIII. And the prevalence is about 1 in a million. We also have qualitative deficiencies, which are broken up into 4 distinct categories. We have a type 2A von Willebrand disease, which has short multimers. Type 2B von Willebrand disease, which is an accentuated plated binding, which results in enhanced risk for thrombosis. So when we look at von Willebrand disease, we normally associate with an increased risk for bleeding, especially if we have absence of or deficiency in a type of qualitative deficiency. But type 2B, because of its ability to bind, it causes enhanced risk for thrombosis. We have type 2M, which is a defective glycoprotein 1b binding site. And then we have a type 2N von Willebrand disease, which is the inability or a mutation within the von Willebrand molecule, which doesn't allow factor VIII to properly bind. And of course, we have acquired von Willebrand disease, which can be seen in a number of pathological conditions. For example, patients who have multiple myeloma can have an acquired von Willebrand type of picture, or patients who have undergone or recently undergone some type of surgical procedure. For example, when you do an aortic valve replacement procedure, if the valve doesn't sit within the heart in a sufficient manner, it can result in acquired von Willebrand disease because there's turbulent blood flow around the valve, resulting in enhanced thrombotic risk. Now, I'm not going to go into great detail, but we'll see here that we have the type 3, which is the virtual absence of von Willebrand disease. You can see here that it is A, autosomal recessive, type 2A, 2B, 2M, and 2N, but also there's an additional category here that I want to also bring up. It's called type 1C. Now, type 1C is an increased clearance of von Willebrand disease. For whatever reason, our body targets the von Willebrand that we make within our endothelial layers or endothelial cells, specifically within the vivo-Pallade bodies, and essentially what this results in an antibody that attaches to von Willebrand and reduces and causes and results in increased clearance. Oftentimes, this can be misrepresented or misclassified or confused with that of a type 1. So in situations where we do have that type of kind of question, we can go ahead and do additional analysis, which I'll talk about in the coming slides, which is the propeptide analysis, which allows us to differentiate a type 1 versus a type 1C von Willebrand disease. So when we look at the first line of testing for von Willebrand disease, one thing that we typically do is platelet aggregation studies. They can be done either during a traditional platelet aggregometer or using a point-of-care device like the PFA 100. Or then we transition to a factor 8 activity, von Willebrand antigen, and of course looking at our activity, which now we can talk about Ristocetin cofactor activity assays, as well as the newer assays like the GP1BM in-event activity assay, and of course the GP1BR. Most oftentimes, if there's a strong clinical history for von Willebrand disease, one can run a quick point of care or PFA 100 or platelet function analyzer, which is basically, it replaces the traditional bleeding time that was once done in clinical laboratories. For those that are not familiar with the bleeding time, this was a kind of an archaic test that literally the physicians would place a cut on a patient's forearm with a razor blade, allowing and then starting a stop clock or stopwatch. Once the bleeding had essentially stopped on the forearm, the stopwatch was stopped, and then that resulting time or closure time was the patient's bleeding time. And of course, now this is no longer used in clinical practice. But what often, if there's a strong clinical suspicion of a bleeding dysfunction, either platelet dysfunction or a von Willebrand disease, a PFA 100 will be performed. In this particular test, here's just a simple depiction of the PFA 100 analyzer. A drop of anticoagulated blood is put into a cuvette, and essentially the blood is pushed through at a specific shear rate. And what this test actually does is it measures two things. It measures, one, the ability of the plate to adhere. That requires von Willebrand. And second, it measures the ability of the plates to aggregate in response to agonists. So the cartridges have either collagen plus ADP or collagen plus epinephrine. We have a number of reference ranges or normal closure times for patients. As the blood is pushed through the aperture, it results in the activation. Once there is a significant closure or occlusion of that aperture, that clot time in seconds is measured. The importance of PFA 100 has a very good negative predictive value, and therefore it's able to exclude the presence of a disease. So if we have normal closure times for both our cartridges, either with epinephrine and collagen or ADP and collagen, that effectively can exclude a severe platelet dysfunction or severe von Willebrand disease. On the other hand, if we have abnormal closure times, that typically result in the possibility of having a severe platelet dysfunction or von Willebrand disease. So this would be most often your very first assay if there is a suspected bleeding or a suspected disease within your primary hemostatic pathway. The second line is really measuring von Willebrand antigen, or how much of the molecule is actually present. So this is a simple capture and detection antibody technique that uses an immunoturbidimetric process. So we have our capture antibody that measures the amount of von Willebrand in the patient sample. Then we have our detection antibody, which gives us the amount of von Willebrand the patient has. Our second assay is really measuring the functional activity. So we have one assay that measures the amount of molecule present, the antigen, and now we have our second assay, which is our functional activity assay. What was interesting is the first test that was developed was utilized to measure the functional activity of von Willebrand was using a antibacterial agent, and this was Ristocetin. It was initially discovered as it was given to patients to treat bacterial infection, and what they noticed is many of these patients resulted in bleeding disorder, or a thrombotic disorder, excuse me. And the reason for that is Ristocetin, what it effectively does is it causes the von Willebrand to unfold and allowing it to bind to the plate, so resulting in enhanced thrombosis. So what they did is they went ahead and developed this assay. The traditional, the assay that was most often used was a platelet aggregation assay, where in this case you had platelets or lyophilized plates that had the glycoprotein 1b, added Ristocetin. It caused the unraveling of von Willebrand and the subsequent of the patient's von Willebrand, resulting in an aggregation. We also now have more automated assays like the BC von Willebrand reagent. What that does is it causes, again, a micro titer bead, or microbead has the glycoprotein 1b. It's added to the reaction mixture. Ristocetin is added, causing an unraveling and then measuring the activity. Now, what's interesting is that there's an important distinction that needs to be made. When we look at soluble agonists like ADP, epinephrine, thrombin, collagen, or thromboxane, for example, they really result in the aggregation. That is, it results in that conformational change of the most widely the very specific or the highly concentrated glycoprotein to B3A that's found on platelets, causing that to undergo this conformational change, results in the aggregation or the binding of the fibrinogen bridge. When we add Ristocetin, what it does is it causes the plates to become, quote unquote, stickier. Remember we talked about how von Willebrand is a kind of a sticky string? Well, that's exactly what Ristocetin does. It causes the von Willebrand to become that sticky string that attaches those plates, then resulting in the activation of the glycoprotein 1b. So I'd like to make that important distinction, and this really plays an important role, especially when you're trying to differentiate a type 2A versus a type 2B von Willebrand disease. We'll talk about this, but just we know that when we actually have a low dose Ristocetin in patients who have a type 2B von Willebrand disease, it's called enhanced aggregation, and that's where it's important to differentiate between 2A, increased risk for bleeding, and 2B, more of an increased risk for thrombosis. Many clinical laboratories and clinicians really focus in on using the activity and antigen and really looking at their ratios. But what we can see in this particular slide is we have patients who have von Willebrand disease type 1. We see we have a broad distribution of both your activity and factor VIII. As we go from 2A to 2B, again, we see that there is similar distribution, especially for activity and factor VIII. But as we look at type 3, where we have the virtual absence of von Willebrand disease, we have a complete suppression of von Willebrand or activity, and then we have a decreased response in type 1 or factor VIII activity because there's increased proteolysis because there's no molecule to essentially protect it. And that's why it makes it important that, and challenging it at the same time, to diagnose von Willebrand disease, because what happens in a particular case with type 3, you'll have a decreased factor VIII. So if the patient is male, it could essentially mimic that of a hemophilia A type of picture. So having all the tools in the toolbox to properly assess these patients is absolutely critical. So in 2021, a number of agencies got together, like the American Society of Hematology, the International Society of Thrombosis Hemostasis, National Hemophilia Foundation, as well as the World Hemophilia got together and really looked at the guidelines and says, well, we need to kind of reevaluate how we diagnose von Willebrand disease. And within the guidelines, there's a section that really suggests that newer assays to measure von Willebrand platelet binding activity are recommended, like the glycoprotein 1b activity assay GP1BR over your traditional Ristocetin cofactor activity assay. And the reason for this kind of change in heart, or this kind of reevaluation of the guidelines, really stemmed from the Ristocetin cofactor assay as being a problematic assay. One of the challenges is that it had its lower limit of detection was very broad. When I was a laboratory director, when I ran our Ristocetin cofactor activity assay, I did not feel comfortable reporting values that were less than 20% because of that very or high degree of precision. Because of this imprecision, especially at the low end, it made it challenging to report those values. That's number one. Two, when we're using the Ristocetin cofactor activity to antigen ratio, which a lot of our guidelines base on that ratio, if, for example, we had a sample that had a Ristocetin cofactor activity of less than 20%, obviously now you're unable to accurately assess the patient's ratio, therefore making it challenging to differentiate the different types of von Willebrand disease. Third, it was flawed because of a specific polymorphism that was found. This polymorphism is essentially a benign polymorphism. It's the D147H polymorphism that shows a low Ristocetin cofactor activity. And it is highly prevalent in the African American population at about 63%, and about 17% in the Caucasian population. And what this showed is there was a decreased amount of Ristocetin cofactor activity, resulting in a misclassification or the classification of patients with von Willebrand disease when in reality they did not have it. So this kind of resulted in this kind of moving towards newer assays like the infant von Willebrand activity assay. So the infant von Willebrand activity assay uses a recombinant glycoprotein 1b with two gain-of-function mutations in a kind of a latex-based glycoprotein 1b binding assay. Basically, we have an antibody that binds the patient's von Willebrand, and then we have the second B that comes in, or reagent 3 as it's called, which has this gain-of-function mutation, and it causes an immunoturbidimetric or agglutination of the sample, resulting in measuring the patient's activity. And I want to point out this is not Ristocetin based, so therefore it's not subject to the D147H2 polymorphism that the Ristocetin based assay was subject to. I particularly like this slide because it kind of takes the three main assays. You have the von Willebrand, the Ristocetin cofactor activity, where again here you see the patient's von Willebrand, which has the GP1 binding sites. You have either the platelets or these beads that have glycoprotein 1b. You add Ristocetin, causes the agglutination. The GP1BR is similar in nature, with the difference is that it uses a latex bead that has the recombinant glycoprotein 1b. It also uses Ristocetin and then essentially results in platelet agglutination. Now, this glycoprotein 1BR assay is available outside of the U.S. Studies have shown that it's not subject, even though it does use Ristocetin, to this D147H2 polymorphism. On the other hand, what's now currently available in the U.S. is this glycoprotein 1b of this Innovance assay. Again, as I showed in the previous slide, you have your patient's von Willebrand factor, you have the various binding sites, you have the microbead that has the glycoprotein 1b, and then you also have the recombinant, those two gain-of-function mutations, which facilitates in the unraveling and the subsequent platelet agglutination of the measurement instrument. There's another assay that is available. It's a von Willebrand antibody assay. It has been marketed as a functional assay, but it's truly not, in my opinion, not a truly functional assay because it is an antibody to the reactive center of von Willebrand. So therefore, it's measuring that, yes, I find the reactive center, that's not measuring the true functional activity, like, for example, the GP1BM activity assays. So there's a lot of discussion back and forth, but now with this new assay that's currently, has been granted FDA approval and is available in the U.S., I think it's, in my opinion, a game changer for facilitating the better diagnosis of von Willebrand disease. I talked about the importance of looking at the activity to antigen ratio. And if you think about it intuitively, if you have a quantitative deficiency like a type 1 or a type 3, you would expect that your antigen and activity to be decreased, roughly the same. So you would maintain that 1-to-1, let's say, ratio, or a ratio of 1. But what was challenging, especially in diagnosing von Willebrand disease, is that kind of broad variability, especially in patients who had normal or did not have von Willebrand disease, those that had a type 1 and those that had a type 2. And here we look at different ratios, and there is debate on which ratios would be appropriate. Typically, many labs use a 0.7 ratio, so that if your activity to antigen is greater than 0.7, it could indicate a type 1, or it could be a normal patient. Or if it's less than 0.7, it could indicate a type 2. But now what we're seeing is that ratios being more and more brought into question. Is a 0.7, a 0.6, or even a 0.5 ratio appropriate? And what you can see here, and this is why I particularly like this slide, is when we look at the Ristocetin cofactor, you see there's kind of a lot of overlap, especially in the type 1, type 2, or type 1, type 2, as well in patients who have normal. However, when using an activity assay, what you can see is there's more of a differentiation, more of a kind of a gap. There's still a little bit of overlap, but it doesn't seem that the overlap is as pronounced as it was if you're using the Ristocetin cofactor activity assay. And again, it is being discussed on which is the appropriate ratio to use. I think some laboratories and some discussions that I've had recently kind of have highlighted that, transition to that 0.6 ratio may be more appropriate. Now, as we get better and better data, having more robust assays like the Innovent's activity assay, perhaps would allow us to differentiate this and use more of a streamlined cutoff for von Willebrand disease. Here's a nice table that kind of looks at the different types of von Willebrand disease as well as with the different types of assays. So here, for example, if we're looking at a quantitative deficiency like a type 1 or a type 3, you'd expect your functional activity assay as well as your antigen to be significantly decreased, whereas as type 3, you would expect to have undetectable levels in both your antigen and activity. For a type 2A picture, remember we talked about type 2A being a qualitative deficiency, and most often that represents an absence of those higher molecular weight multimers, which play that important role in recruitment of platelets. Well, here we have a dysfunction in the functional ability, so your activity assays will be decreased, where your antigen assays in theory should be roughly normal, so therefore you would have a low antigen or activity to antigen ratio, allowing us to kind of differentiate the different types of von Willebrand disease. So once we've gone through that kind of first line of testing, establishing, of course, whether or not the patient has a strong bleeding history, so allowing us to go ahead and do the platelet tests or the PSA, looking at your factor 8, Ristocetin cofactor, or your activity or functional von Willebrand tests, and of course looking at your antigen. Transition to that second line, more the confirmation. So we look at multiple analysis. We look at propeptide, we look at DDAVP testing, as well as we look at collagen binding and factor 8 binding. To this day, multiple analysis is considered to be essentially the gold standard for the diagnosis of von Willebrand disease. And the reason for that is because it allows you to differentiate and look at the different types of multiple distribution as you go in an agarose gel. Challenge with this particular assay is, one, it's very time consuming and it's technically challenging. When I was a clinical chemistry fellow, I was very fortunate enough to work in Dr. Edward Sadler's laboratory, who was one of the preeminent researchers in von Willebrand disease, and I was able to get my feet wet with this multiple analysis and saw how technically challenging it was. But once you're able to cast a gel and you're able to see the different multiple distributions, this is just a cartoon representation, you would see here that patients who have a normal distribution, a type 1, and those patients who have a type 2A or 2B or even a type 3 where you have the absence of those larger multimers and, of course, the complete absence of. Of course, we also have the ability to do genetic testing for many of these patients, but sometimes doing the multimer analysis at least allows you to treat the patient appropriately by distinguishing and differentiating the different types of von Willebrand disease. Now, if we look at multimers as a whole, it's really kind of cool the way that we have these kind of multimer distributions. So really, when you look at the separation of the multimers on an agarose gel, what we're seeing is we've seen these kind of triplet structures or this quintuplet structures. And really what this basically says is that this is where Adam's CS13 cleaves or results in the proteolysis. And you can essentially visualize these by these agarose gels. And this is just an indication here where we have an intermediate resolution gel. You can have 3 distinct structures, which indicates where Adam's CS13 has caused the proteolysis. And then if you have a higher resolution gel, you actually see this quintuplet kind of structure, allowing to see, again, a better distribution or a breaking up of these bands. And a lot of information can be distilled from these multimer results. Here's just an example of a gel that was published in Dr. Sadler's lab. And again, my gels never looked like this, but what this basically shows us is, again, what I showed in that cartoon representation. You have your triplet structure, you have your normal plasma indicated as NP or normal patient, a type 1 where you have a reduced signal, you have a type 2A where you have the absence of those higher molecular multimers, a type 2B is still you have of those very high molecular multimers are absent, but you have those intermediate, and this is where we talk about increased platelet binding, and of course we have our type 3. This slide really shows a patient who has TTP. I mentioned this before. These are patients who have Adam's CS13 deficiency. Remember, it is that molecule that regulates the size of von Willebrand. So in patients who have Adam's CS13, they have these very, very large multimers resulting in hand thrombosis, and that's the decrease in platelets resulting in this condition called TTP or thrombotic thrombocytopenic purpura. And of course, we also see comparatively when we see a patient who has a normal patient or a normal plasma, that difference in size of the molecular multimers. There was an excellent review that was published in Seminars in Thrombosis and Hemostasis, which shows how we can actually diagnose different types of von Willebrand disease just by looking at the multimers. So this is just the example that I got from the paper. But what you can see here, for example, in column B, when comparing that to the normal patient plasma, this would be consistent with patients who have type 1. In column C, this result represents a type 1C. I talked about that before, where type 1C indicates increased clearance of von Willebrand disease. In columns E and F, very similar, we differentiate between type 2A and type 2B. Again, here, if we really want to make that distinction, we can also activate platelets using low-dose Ristocetin to differentiate 2A from 2B. In column J, you have our patients who have type 2M, and now we have a normal multimer pattern, but you can see it's more of kind of a smeary appearance here, and this sometimes can make it challenging. Remember, we've talked about type 2M being the ability of von Willebrand to bind to collagen. And there has been discussion that in order that perhaps type 2M is sometimes being misdiagnosed or misdiagnosed because of not being able to distinguish this. Well, one assay, and I'll talk about this, utilizing the collagen binding assay. And if you're looking at, let's say, your activity to antigen, that is using your Innovent's activity assay to your antigen and using a collagen binding to antigen, having a low activity and antigen, but a normal collagen binding to antigen may indicate the presence of a type 1M. So it's really being able to distinguish and utilizing all the tools, as I said, in the toolbox to accurately assess it. And in column K, we have a type 3 von Willebrand disease, and L through N is really an acquired von Willebrand disease. And interestingly, if you look at column N, this is a patient who has multiple myeloma, and what you can essentially hear, it leads to an absorption of the multimers, or even increased clearance by various monoclonal antibodies, giving kind of this very difficult or smeary picture. So looking at it, see how much information we can get from multimer analysis, I think is quite impactful, especially when we're trying to diagnose very challenging cases. I'm not going to go into great detail. Again, this is the propeptide analysis. This is a technically challenging assay. Most often it's not done in routine clinical laboratories. This is an assay that's most often sent out. It's an ELISA-based assay, send out to more of a specific reference labs, especially if there's the need to distinguish between a type 1 and type 1C, if we don't have the ability to run a multimer analysis. Again, multimers as well are technically challenging, and they're often mostly sent out to laboratories. They're specialized reference laboratories for analysis. The importance of diagnosing von Willebrand disease. So if we know that these patients, for example, are increased risk for bleeding. So in many patients who have a type 1 von Willebrand disease, what they'll do is if they're about to undergo any minor or even major surgical procedure, what often is done is they are given a desmopressin or DDAVP. And in those patients that have reduced synthesis, what the DDAVP is going to do is essentially going to cause an increased amount of von Willebrand that's going to be made or released through the Vivo Pilati bodies. So you would get a pre-DDAVP, a post, 30 minutes post, 60 and perhaps even 90 and maybe 120 depending on the laboratory and what the clinician wants to see. And you'll see a dose response, that you see a gradual increase in the release of von Willebrand, and it peaks at around 60 to 90 minutes, and then eventually it goes down. What this indicates to the clinician, if this patient has a type 1 von Willebrand disease, that this patient most likely will be protected if they're about to undergo, let's say, a minor surgical procedure, or even under dental extraction, they'll be protected if they need to be given DDAVP. Now, on the other hand, if patients have a 2A, what's going to happen is your activity, there's going to be virtually no increase. Because remember, that's the dysfunctional protein that's unable to have normal von Willebrand activity. Whereas your antigen may increase, but you're going to have a disproportionate increase. So that's why it's important to distinguish between patients who have a type 1 versus a type 2, because patients who have type 2 will not be protected if they're given DDAVP. Most often these patients would require some other form of replacement therapy, as patients who have type 3 would also require a very similar type of protection. So again, distinguishing by using your first line and your second line testing, which is your multimers, to really differentiate what type of von Willebrand disease the patient has. I mentioned this before, the collagen binding assay really measures the binding of von Willebrand to collagen, and preferentially that of the high molecular weight multimers, and is therefore sensitive to von Willebrand variants characterized by the absence of larger von Willebrand multimers. So for example, we talked about type 1B, type 2M. You'll still have the ability of having those larger multimers, so you might have a normal collagen binding assay, but in patients who have a type 2A or 2B, where the higher molecular multimers are quote-unquote dysfunctional, you should have a low collagen binding, in this case, a collagen binding to antigen ratio that would be significantly low. So having, like again, all the tools in the toolbox, and I've said this a couple of times already, but it's really important to have those tools available to adequately assess patients who have von Willebrand disease. Another assay that's available is your factor VIII binding. Again, this is utilizing a similar technique that we've talked about, having a capture and detecting the antibody. And really, in this particular case, you're measuring the ability of von Willebrand to bind to factor VIII. And again, this is sometimes can be a very rare instance, and we have a type 2N von Willebrand disease. In this particular case, it could also be misrepresented or misdiagnosed with patient who has a hemophilia A type picture. So again, that's why it's important to be able to diagnose this patient, again, using a factor type 2N assay. Technically challenging, not routinely done in many clinical laboratories, and this is an assay that would be most likely sent off to our reference lab. I want to kind of quickly change gears and talk about the Innovent's von Willebrand activity assay that was recently cleared by the FDA here in the United States. So we talked about this assay before. It's really composed of really two specific reagents. Reagent one is you have a polystyrene latex particle that's covered with an anti-glycoprotein 1b fragment. And what essentially this does is able to bind to the A1 domain of the patient's von Willebrand. Once this happens, then you have a second antibody, or in this case reagent 3, that contains a gain-of-function mutation, specific to gain-of-function mutations on the glycoprotein 1b fragment. And this binding of the microparticle to the latex bead to the patient's von Willebrand results in an agglutination. And this measures the functional activity of von Willebrand in the patient sample in the absence of Ristocetin. Remember, we talked about how Ristocetin can be subject to the D147H2 mutation polymorphism that's found in African Americans as well as Caucasians. So this is Ristocetin independent, it's not subject to that polymorphism. The assay, the Innovent's von Willebrand activity assay, can be run on both systems that Siemens has to offer. It can be run on both the BCS XP system as well as the traditional Sysmex CS2500 and 51 series of instruments. What the difference is, the main difference is the BCS XP actually has two settings for the calibration curve. You have a low setting, and then you have a medium to high setting. Whereas in the CS20 and the CS series, there's just one setting. Here, when we look at, do a quick method comparison of the BC von Willebrand reagent, that is the Ristocetin-based assay, to that of the Innovent's von Willebrand activity assay, you see a very good correlation between both the assays, showing that similar performance in the by measuring the activity levels for Ristocetin or for von Willebrand activity. Here, I'd like to highlight the precision of the von Willebrand activity assay, specific at the medical decision point. Typically, that's around 50%. And we'll see here at the BCS XP, it has a CV of around 1.6%. The CS2500 and the 5100 have around a 2 and a 1% respectively. And why is it important specifically at that decision level, around 50%, is patients who have a blood group O typically have a low von Willebrand activity, and typically that's around 30 to 50%. We can have that questionable, or kind of, is it associated with a blood group O, or is it true of factor of von Willebrand deficiency? And patients who have a blood group A, B, and AB blood groups have higher values. So it's important at that medical decision point, that 50%, to have a very good precision. And of course, there's a very good precision at the low end as well. In this case, looking at the 28%, again, covering that 30 to 50%, again, showing very good precision. And low end precision, again, is very good at around 2 to 1% on the CS series of instruments. As we were preparing to get this particular assay through the FDA, and we were able to do a reference range study looking at those different blood groups, and you can see patients who have blood group O typically have around a 49 to 178%, let's say, factor activity on the Innovent's von Willebrand activity, and patients who have a non-O blood group go from 60 to 214% roughly. And that's what becomes important to one when looking at von Willebrand's patients. It's important to be able to assess and look at the blood groups. Oftentimes when I was signing out cases, I would look at von Willebrand results and really question whether or not, this is truly representative of a von Willebrand disease when I saw a low von Willebrand activity and antigen level. Oftentimes I would ask to see whether or not there was a blood group on the patient. If the blood group O was O, then I would be more comfortable saying that this is low normal consistent with the patient's blood group status. So again, knowing the clinical history, having an accurate and good clinical history on the patient as well as a family history is really important for selecting the diagnosis of von Willebrand disease. But what also has been challenging, especially when we looked at our pediatric population, is being able to accurately assess these. And we were very fortunate enough to do a kind of a quick study on healthy children. Again, looking at blood group O and blood group non-O patients, again, being able to define newer reference ranges, allowing our clinicians as well as our many hospital laboratories to be able to look at these results and effectively validate reference ranges based on the studies that were done here. And here's just some quick take-home messages. We talked about hemostasis, and it's really composed of those three distinct phases: remember, primary, secondary, and tertiary hemostasis. And when we talk about von Willebrand disease, it's really associated with that primary hemostatic defect and the importance that it plays when binding and recruiting platelets to the area of injury. New guidelines recommended newer assays for assessing von Willebrand platelet binding activity. And the Innovent von Willebrand activity assay facilitates better diagnosis of von Willebrand disease and ultimately improving patient care. And I think as we start to use this assay more and more, since it was recently cleared in the FDA, we'll see that we're getting better diagnosis and essentially improving patient care for these patients to be diagnosed with.
Thank you, John, for your informative presentation. Before we start the Q&A portion of the webinar, we have a warm-up audience poll question for you. I think you can see it on your screen. The question is, are you considering implementing a GP1BM type assay for von Willebrand? You can see the choices there. Please vote. So I think you guys have had a chance to do the voting on this question. So if you'd like to go, ahead, we can switch over to some of the audience questions now. So for our first audience question, came in transitioning from the Ristocetin cofactor activity to the GP1BM activity assay, our lab noticed some discrepancies when doing the method comparison. Could you explain these differences?
Sure. So with any, with any new lab or new assay, there's always going to be some differences. So we know that the Ristocetin assay was fraught with a lot of inaccuracies, specifically towards that low end of the curve. So when you're looking at those types of patients, obviously you would expect differences because now you're able to report a value. When I was a medical director at a laboratory, we used the traditional old-fashioned Ristocetin assay that was done on a chronolog aggregometer. And quite honestly, I never felt confident reporting results less than 20%. So now with the assay, with this specific assay, the GP1BM assay, you actually would go lower. So now you're able to generate a value, especially at that low end. But I think the main question is really looking at that medical decision point where you would be really concerned about diagnosing of von Willebrand disease. And so when looking at those and doing kind of a really a sample-to-sample comparison is really thinking about, well, will this value change clinical decision based on the other laboratory values that I have? So it's explainable, again, methodological differences, but again, really looking at the clinical decision points, really trying to figure out exactly if that value would change clinical management is really imperative. So it's really looking at these results as a whole and not as actually just doing an individual result comparison. Hopefully that answers the question.
Thanks, John. We've got another question from the audience. Could we give ADH for treatment of von Willebrand type 1?
So I'm assuming the ADH is referring to antidiuretic hormone or vasopressin. So most oftentimes DDAVP or desmopressin, which is a synthetic analog, to that of vasopressin, is most often given to patients who have type 1 von Willebrand's disease. So to kind of answer the question, if giving vasopressin is recommended, I haven't seen any literature that recommends that. But of course, DDAVP is a staple for type 1 von Willebrand disease. But I also would want to point out that making sure that the patient is given DDAVP prior to any major surgical procedure, ensuring that there's an adequate response, doing a pre and post DDAVP is important to ensure that the patient will be adequately protected during whatever or during the surgical intervention that the patient is about to undergo.
Thanks, John. Here's another one from the audience. In your experience, can type 3 multimers have 1 or 2 trace bands?
So when I'm assuming we're talking about obviously the multimer analysis, most oftentimes when I've done any type of multimer analysis, I haven't seen any trace bands. But again, depending on how each individual lab does their multimer analysis. But I would imagine when looking at some the multimers that I've seen, I could probably see maybe 1 trace band so on the agarose gel if we're doing it the traditional old-fashioned agarose gel way.
Okay, and we have one more. Our lab occasionally gets a slightly low collagen binding assay result when all the other results are normal. Any idea what this means?
So with any, depending on how low, excuse me, the CBA results typically come as. So I typically chalk it up to an analytical variation if the clinical signs and symptoms don't suggest von Willebrand's disease, and the laboratory evaluation when we look at factor 8, von Willebrand antigen, and in this case our intervense activity assay or the Risto or whichever activity the lab is using. So if I say that the analytical variation or what I would expect to be type of analytical error to be, let's say, plus or minus 10%, I probably wouldn't think too much of it. However, if that is greater than your analytical variation of what you would typically see, then perhaps repeat testing at a later time to verify if these results would be ideal or appropriate. And again, it all depends on the clinical condition of the clinical situation the patient's experiencing.
Thanks, John. There's one more here. There has been some discussion around the activity to antigen ratio. Which activity to antigen ratio do you recommend?
So it's been a kind of a topic of discussion amongst various papers that I've read so far. And the ratio being either the activity, that is the antigen ratio, going from 0.7 to 0.6 to 0.5. It hasn't really been a consensus statement as to what the ideal ratio would be. In one of the papers that I recently read, which looked at, I believe, NASCOLA proficiency testing results, they were kind of leaning towards recommending a 0.6, which is a more robust, I guess, way of assessing the activity to antigen ratio. I think hopefully when the guidelines are kind of reanalyzed and more studies have been done, we'll have more of an ideal ratio now also that we have this intervense activity assay on the market here in the US, that is.
All right. Well, thanks, John. I think that's really much all the time we have for questions today. Thank you again, John, for your time and your important discussion on this topic. We at Siemens Healthineers would like to thank LabRoots for today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. Until next time, take care, everyone. Goodbye.